Hello, nursing students. Today we are going to be covering med-surg or concepts. This is Understanding Medical Surgical Nursing, the 6th edition by Williams and Hopper. Chapter 6 is Nursing Care of Patients with Fluid, Electrolyte, and Acid-Base Imbalances. This is a two-part PowerPoint, so I'm not sure where the second one starts, but I will start reading here on page 52. Have you ever wondered why you get thirsty? The body is continually changing. Water supports these changes. Approximately 60% of a young adult's body weight is water. Older people are less than 50% water, and infants are between 70% and 80% water. Fat cells do not contain water. Therefore, people with a higher percentage of fat cells have a lower percentage of water. In addition to water, body fluids also contain dissolved solid substances called solutes. Some solutes are electrolytes. Some are non-electrolytes. Electrolytes are chemicals that can conduct electricity when dissolved in water. Looking at this PowerPoint, she's got a video here we can try to look at in just when I get to the bottom of this page. Examples of electrolytes are sodium, potassium, calcium, magnesium, acids, and bases. These are discussed in this chapter. Non-electrolytes do not conduct electricity. Examples include glucose and urea. Okay, so I'm going to see if I can get this PowerPoint to work for us. And I may have to share a different screen. I believe I will need to stop sharing and reshare. This one says the video is unavailable, so let's skip that and continue on the next page. So, fluid balance. Fluids are located in various compartments within the body. Fluid inside the cells is referred to as intracellular fluid, ICF. Fluid outside the cells is called extracellular fluid, ECF. ECF can be further divided into 3 types. There's interstitial fluid, intravascular fluid, and transcellular fluid. Control of fluid balance. The primary control of water in the body is through pressure sensors in the vascular system that stimulate or inhibit the release of antidiuretic hormone, ADH, from the pituitary gland. A diuretic is a substance that causes the kidneys to excrete more fluid. ADH works in just the opposite way. ADH causes the kidneys to retain fluid. If fluid pressures within the vascular system decrease, more ADH is released and water is retained. If fluid pressures increase, less ADH is released and the kidneys eliminate more water. Movement of fluids and electrolytes in the body. Fluids and electrolytes move in the body by active and passive transport systems. Active transport depends on the presence of adequate cellular adenosine triphosphate, ATP, for energy. The most common examples of active transport are sodium-potassium pumps. These pumps are located in the cell membranes. They cause sodium to move out of the cells and potassium to move into the cells when needed. In passive transport, no energy is expended specifically to move the substances. Generally, body movements aid passive transport. The 3 passive transport systems are diffusion, filtration, and osmosis. Diffusion is the movement of a substance from an area of higher concentration to an area of lower concentration. If you pour cream into a cup of coffee, the movement of the molecules will eventually cause the cream to be dispersed throughout the beverage. If you stir the coffee, this process occurs at a faster rate. Body movement assists passive transport, like stirring the coffee. It causes diffusion to occur at a faster rate. Filtration is the movement of both water and smaller molecules through a semi-permeable membrane from an area of high pressure to an area of lower pressure. A semi-permeable membrane works like a screen that keeps larger substances on one side and permits only smaller molecules to filter to the other side of the membrane. Filtration is promoted by hydrostatic pressure differences between the areas. Hydrostatic pressure, sometimes called water pushing pressure, is the force that water exerts. In the body, filtration is important for the movement of water, nutrients, and waste products in the capillaries. The capillaries serve as a semi-permeable membrane, allowing water and smaller substances to move from the vascular system to the interstitial fluid. Larger molecules and red blood cells remain inside the capillary walls. Osmosis is the movement of water from an area of lower substance concentration across a semi-permeable membrane to an area of higher concentration. The power to pull water toward an area of higher concentration is referred to as osmotic pressure. This process continues until the concentration is the same on both sides of the membrane. The term osmolarity refers to the concentration of the substances in body fluids. The normal osmolarity of blood is between 270 and 300 milliosmoles per liter, OSM/L. Another term for osmolarity is tonicity. Fluids or solutions can be classified as isotonic, hypotonic, or hypertonic. A fluid that has the same osmolarity as the blood is called isotonic. For example, 0.9% normal saline solution is isotonic to the blood. It is often used as a solution for intravenous therapy. A solution that has a lower osmolarity than blood is called hypotonic. When a hypotonic solution is given to a patient, the water in the solution leaves the blood and other ECF areas and enters the cells. Hypertonic solutions exert greater osmotic pressure than blood. When hypertonic solution is given to a patient, water leaves the cells and enters the bloodstream and other ECF spaces. Fluid gains and fluid losses. Water is very important to the body for cellular metabolism, blood volume, body temperature regulation, and solute transport. Although people can survive without food for several weeks, they can only survive a few days without water. Thirst is the major indicator that a healthy adult needs more water. Water is gained and lost from the body every day. In addition to liquid intake, some fluid is obtained from solid foods, like watermelon. When too much fluid is lost, the brain's thirst mechanism tells the individual that more fluid intake is needed. Older adults are more prone to fluid deficits because they have a diminished thirst reflex and their kidneys do not function as effectively. An adult loses as much as 2.5 liters of sensible and insensible fluid every day. Sensible losses are those of which a person is aware, such as urination. Insensible losses may occur without the person recognizing the loss. Perspiration and water lost through respiration and elimination of feces are examples of insensible losses. Fluid imbalances are common in all clinical settings. Older people are at the highest risk for life-threatening complications that can result from either fluid deficit, more commonly called dehydration, or fluid excess. Infants are at risk for fluid deficit because they take in and excrete a large proportion of their total body water each day. Dehydration. Although there are several types of dehydration, only the most common type is discussed in this chapter. Dehydration occurs when there's not enough fluid in the body, especially in the blood, the intravascular area. Pathophysiology and etiology. The most common form of dehydration results from a loss of fluid from the body, resulting in decreased blood volume. This decrease is referred to as hypovolemia. Hypovolemia occurs when the patient is hemorrhaging or when fluids from other parts of the body are lost. For example, severe vomiting and diarrhea, severely draining wounds, and profuse diaphoresis, or sweating, can cause dehydration. Hypovolemia can also occur when fluid from the intravascular space moves into the interstitial space. This process is called third spacing. Examples of conditions in which third spacing is common include burns, liver cirrhosis, and extensive trauma. As described previously in this chapter, the body initially attempts to compensate for fluid loss by a number of mechanisms. If the cause of fluid loss is not resolved, or if the patient is not able to replace the fluid, dehydration occurs. Prevention. You can help prevent dehydration by identifying patients who have the highest risk for developing this condition and intervening quickly to correct the cause. High-risk patients include older adults, infants, children, and any patient with one of the conditions listed in box 6.1. Also see gerontological issues, dehydration. So in box 6.1, common causes are diarrhea, diuretic therapy, draining abscess or fistula, fever, gastrointestinal suction, hemorrhage, ileostomy, long-term nothing by mouth status, profuse diaphoresis or sweating, systemic infection, and vomiting. Signs and symptoms. Wait, did I skip something? Let me see. Oh, adequate hydration is another important intervention to help prevent dehydration. Encourage patients to drink adequate fluids. Adults need 30 ml per kilogram per day of fluids, which is over 2,000 milliliters. If a patient is unable to take enough fluids by mouth, alternate routes may be necessary. Signs and symptoms. Thirst is the initial symptom experienced by otherwise healthy adults in response to hypovolemia. As the percentage of water in the blood goes down, the percentage of other substances goes up, resulting in the thirst response. As the blood volume decreases, the heart pumps the remaining blood faster but not as powerfully, and this leads to a rapid, weak pulse, rapid, shallow respirations, and low blood pressure. The body pulls water into the vascular system from other areas. This results in decreased tear formation, dry skin, and dry mucous membranes. A dehydrated person will have poor skin turgor, Turgor is considered to be poor if the skin is pinched and a small tent or wrinkle remains, called tenting. A dehydrated person's temperature increases because the body is less able to cool itself through perspiration. Temperature may not appear elevated in an older person because an older adult's normal body temperature is often lower than a younger person's. Urine output decreases. The urine becomes more concentrated as water is conserved. Dehydration should be considered in any adult with a urine output of less than 30 milliliters per hour, which is 1 ounce per hour. The urine may appear darker because it is less diluted. The patient becomes constipated if the intestines absorb more water from the feces. A major method of evaluating dehydration is weight loss. A pint of water, 16 ounces, weighs approximately 1 pound. Symptoms of dehydration in older persons may be atypical. Okay, so there's a purple box on page 54 called Gerontological Issues. Dehydration. As a person ages, total body water decreases from 60% to 50% of total body weight. This age-related decrease in total body water is secondary to an increase in body fat and a decrease in thirst sensation. These factors increase the risk of developing dehydration. Manifestations of dehydration in an older adult are different from typical manifestations in a younger person. They may include an altered mental status, lightheadedness, and syncope, which is also loss of consciousness or fainting. These occur because a patient with hypovolemia has an inadequate circulatory volume and therefore inadequate oxygen supply to the brain. The learning tip. Do you remember your grandmother saying, "A pint's a pint around the world"? It's a great way to this is on page 55. A pint's a pound the world around. That's the way it is. Okay, my grandmother didn't say that, but, hey, apparently it's a great way to remember how much fluid loss is represented by each lost pound. So a pint is 16 ounces, weighs about a pound. Okay, complications. If dehydration is not treated, lack of sufficient blood volume causes organ function to decrease and eventually fail. The brain, kidneys, and heart must be adequately perfused with blood to function properly. The body protects these organs by decreasing blood flow to other areas. When these organs no longer receive their minimum requirements, death results. Okay, there's a learning tip on page 55 that says the magic fluid number is 30. Healthy adults should drink approximately 30 milliliters of fluid per kilogram of body weight per day, and they should urinate at least 30 ml per hour. This is just a basic rule of thumb and will vary based on individual circumstances. Diagnostic tests. A patient with dehydration usually has an elevated blood urea nitrogen BUN level and elevated hematocrit. Both values are increased because there's less water in proportion to the solid substances being measured. The specific gravity of the urine also increases as the kidneys attempt to conserve water, resulting in a more concentrated urine. Therapeutic measures. The goals of therapeutic measures are to replace fluids and resolve the cause of dehydration. If a patient with moderate or severe dehydration, in a patient with moderate or severe dehydration, IV therapy is used. Isotonic fluids that have the same osmolarity as blood, such as normal saline, are typically administered. Nursing process for the patient experiencing dehydration. Nurses can play a major role in identifying and caring for patients who are dehydrated. Data collection. Assess the patient for signs and symptoms of dehydration. All the classic signs and symptoms may not be present. When assessing an older adult for skin turgor or tinting, assess the skin over the forehead or sternum. The skin over these areas usually retains elasticity and is therefore a more reliable indicator of skin turgor. Also, check mucous membranes, which should be moist. Weight is the most reliable indicator of fluid loss or gain. A loss of 1 to 2 pounds or more per day suggests water loss rather than fat loss. The patient in the hospital setting should be weighed every day. The patient in the nursing home or home setting should be weighed at least 3 times a week if the patient is at risk for fluid imbalance. Weigh the patient before breakfast using the same scale each time, and that is probably a question that might appear in the NCLEX. Weigh the patient before breakfast using the same scale each time. Keep that in mind. Intake and output, I and O, are also typically measured. There's a box on page 55 called Cultural Considerations. Muslims who celebrate Ramadan traditionally fast for 1 month from sun up to sundown. Although the ill are not required to fast, adherents who are ill may still wish to do so. Fasting may include not taking fluids and medications during daylight hours. For a Muslim who is ill and fasting, the nurse may need to alter times for medication administration, including intramuscular medication. Special precautions may need to be taken to prevent dehydration. Nursing, diagnosis, planning, and implementation. Risk for deficient fluid volume or deficient fluid volume, isotonic or hypotonic/hypertonic related to fluid loss or inadequate fluid intake. That would be the diagnosis. The expected outcome is the patient will be adequately hydrated as evidenced by stable weight, moist mucous membranes, and elastic skin turgor. Monitor daily weights and I&O so problems can be detected and corrected early. Plan with the patient and other members of the healthcare team the type and timing of fluid intake. Planning with the patient increases the likelihood that the plan will be followed. Offer fluids often to the confused patient because he or she may not drink independently. Correct the underlying cause of the fluid deficit so it does not recur. Be careful not to overhydrate the patient so fluid excess does not occur. See box 6.2 for best practices for maintaining oral hydration in older people. So I'm going to read box 6.2 now. Maintaining oral hydration in older people. Following are best practice recommendations for maintaining oral hydration in older people. A fluid intake sheet is the best method of monitoring daily fluid intake. Urine-specific gravity may be the simplest, most accurate method to determine patient hydration status. Evidence of a dry, furrowed tongue, mucous membranes, sunken eyes, confusion, and upper body muscle weakness may indicate dehydration. Regular presentation of fluids to bedridden older people can maintain adequate hydration status. Owing the observations that medication time can be an important source of fluids, fluids should be encouraged at this time. Evaluation. The patient who is adequately hydrated will have elastic skin turgor, moist mucous membranes, and stable weight. Patient education. This is on page 56. Teach the patient, family, and significant others of the importance of reporting early signs and symptoms of dehydration to the healthcare provider. At home or in the nursing home, infections can cause fever and sepsis. Sepsis is a serious condition in which the infection invades the bloodstream. The body attempts to decrease the temperature through perspiration. The patient becomes dehydrated as a result and can become increasingly ill. Okay, there's a critical thinking box on page 56. It says, Mrs. Levitt is a 92-year-old widow who has been living in the nursing home where you work for 4 years. Today, she mentions that her urine smells bad and that her heart feels like it's beating faster than usual. You suspect that she is becoming dehydrated. You check her urine and find that it is a dark amber color and has a strong odor. Her heart rate is 98 beats per minute. Blood pressure 126/74. Respiratory rate is 20 per minute. And temperature 99.2 degrees Fahrenheit or 37.3 degrees Celsius. What other data should you collect and what results do you expect? So we could do I think that the specific gravity of the urine would be an easy one to check. And what interventions should you provide at this time? I would say provide some water, encourage her to drink water. How should you document your subjective and objective findings? And what other team members should be informed of your plan for Mrs. Levitt? And how will you know if she is improving? So the answers are at the end of the chapter, so let me take a look at that one. If I can find it here. Okay, so number one, they said, what data should you collect and what results do you expect? Well, you want to check her weight and compare it with previous weights. So dehydration is associated with weight loss. You'll monitor her mental status for disorientation. I'm reading on page 68 right now, by the way. And you'll compare vital signs to the usual vitals and continue to monitor vitals. So the second question was, what interventions should you provide at this time? And the answer is to encourage increased fluid intake. You want to notify the registered nurse or the healthcare provider if Mrs. Levitt is unable to take in additional fluids, or if the fluids do not normalize assessment findings. Number three, how should you document your subjective and objective findings? So subjective, remember that's something that the patient says. Subjective, my urine smells bad and my heart is beating fast. And objective would be what we observe, which would be the patient's urine is a dark amber and strong smelling. The weight is at 112 pounds and the baseline was 116 pounds. So there's been some weight loss. Skin tinting present. VSP 98 beats per minute. BP 126/74 mmHg. And R respiratory rate, RR, 20 per minute. Temperature, T, 99.2, and fluids are encouraged. The RN was notified. So that's what you would document. Number four, what other team members should be informed of your patient's plan for Mrs. Levitt? Well, you'll want to notify the RN, but also the nursing assistant who can help with encouraging fluids during and between meals, as well as monitoring skin condition. Contact the dietary department to obtain beverages Ms. Levitt prefers that do not contain caffeine. And then number five was, how will you know if she is improving? Well, you will watch for her weight to return to her normal weight and for her skin to feel more elastic and for her urine to appear more dilute. And vital signs should also return to baseline. I'm going to go back to page 56 and read under fluid excess. Fluid excess, sometimes called overhydration, is a condition in which a patient has too much fluid in the body. Most problems related to fluid excess result from too much fluid in the bloodstream or from a dilution of electrolytes in red blood cells. Pathophysiology and etiology. The most common result of fluid excess is hypervolemia, in which there is excess fluid in the intravascular space. Healthy adult kidneys can compensate for mild to moderate hypervolemia. The kidneys increase urine output to rid the body of extra fluid. Sometimes, however, the kidneys cannot keep up with the excess fluid. Conditions that cause excess fluid intake are poorly controlled IV therapy or excessive ingestion of water. It can also occur secondary to excessive sodium intake, adrenal gland dysfunction, or the use of corticosteroid drugs. Conditions that can result in inadequate excretion of fluid intake include kidney failure, heart failure, and the syndrome of inappropriate ADH. And these conditions are discussed elsewhere in the book. Prevention. One of the best ways to prevent fluid excess is to avoid excessive fluid intake. Monitor the patient receiving IV therapy for signs and symptoms of fluid excess. In at-risk patients, an electronic controller should be used to control the rate of infusion. Also, monitor the amount of fluid used for irrigation. For example, when a patient's stomach is being irrigated, gastric lavage, be sure an excessive amount of fluid is not absorbed. Signs and symptoms. Vital sign changes seen in the patient with fluid excess are the opposite of those found in patients with dehydration. Blood pressure is elevated, pulse is bounding, and respirations are increased and labored. Neck veins may become distended. Pitting dependent edema, excess water in tissues, in the feet and legs may be present. The skin is pale and cool. The kidneys increase urine output. The urine appears diluted, almost like water. The patient rapidly gains weight. In severe fluid excess, the patient develops moist crackles in the lungs, dyspnea, and ascites, which is excess peritoneal fluid. Complications. Acute fluid excess typically results in congestive heart failure. As the fluid builds up in the heart is not able to properly function as a pump. The fluid then backs up into the lungs, causing a condition known as pulmonary edema. Other major organs of the body cannot receive adequate oxygen, and organ failure can lead to death. Diagnostic tests. In the patient experiencing fluid excess, BUN and hematocrit levels tend to decrease because the extra fluid dilutes the blood. The plasma content of the blood is proportionately increased compared with solid substances. The specific gravity of the urine also diminishes as the urine output increases. Therapeutic measures. Once the patient's breathing has been supported, the goal of treatment is to rid the body of excess fluid and resolve the underlying causes of the excess. Positioning. To facilitate ease in breathing, the head of the patient's bed should be in a semi-Fowler or high Fowler's position. Figure 6.2, which I think I did see it in here. Well, I don't don't know if that's really a semi-Fowler. It looks like about 45 degrees. So in the book, they're showing this is a high Fowler position with oxygen. Okay. These positions allow greater lung expansion and thus aid respiratory effort. Once the patient has been properly positioned, oxygen therapy may be necessary. Oxygen therapy. Oxygen therapy is used to ensure adequate perfusion of the major organs and to minimize dyspnea. So you'll monitor pulse oximetry and respiratory rate carefully. Drug therapy. Diuretics are commonly administered to rapidly rid the body of excess water. A diuretic is a drug that increases elimination of fluid by the kidneys. The drug of choice for fluid excess when the patient has adequately functioning kidneys is usually a loop diuretic, such as furosemide or Lasix. Loop diuretics cause the kidneys to excrete sodium and water. Sodium and water tend to move together in the body. Potassium, another electrolyte, is also lost, and this can lead to a potassium deficit discussed later in this chapter. Furosemide may be given by the oral, intramuscular, or IV route. The oral route is most commonly used for mild fluid excess. IV furosemide is administered for severe fluid excess. The patient should begin diuresis within 30 minutes after receiving IV furosemide. Strict I&O should be monitored, as well as daily weight when a patient is receiving IV furosemide or Lasix. Diet therapy. Mild to moderate fluid restriction may be necessary, as well as a sodium-restricted diet. In collaboration with a dietitian, an HCP prescribes the specific restriction necessary, and this is usually a 1 to 2 gram sodium restriction for severe excess. Different diuretics result in differing electrolyte elimination. Specific diet therapy depends on the medications the patient is receiving and the patient's underlying medical problems. Nursing process for the patient experiencing fluid excess. Data collection. Observe a patient who is at high risk for fluid excess. You'll monitor their I&O carefully. If the patient is drinking adequate amounts of fluid, which would be 1,500 ml per day or more, but is voiding in small amounts, the fluid is being retained by the body. Assess for edema. If it is pitting, a finger pressed against the skin over a bony area such as the tibia leaves a temporary indentation. For patients in bed, check the sacrum for edema. For patients in the sitting position, check the feet and legs. Also, assess lung sounds. Excess fluid accumulation in the lungs can cause crackles. See Chapter 29. As mentioned earlier, weight is the most reliable indicator of fluid gain. Weigh at-risk patients daily. A gain of 1 to 2 pounds or more per day indicates fluid retention, even though other signs and symptoms may not be present. Nursing diagnosis, planning, and implementation. Excess fluid volume related to excessive fluid intake or inadequate excretion of body fluid. Expected outcome. The patient will return to a normal hydration status as evidenced by return to weight that is normal for the patient, absence of edema, and clear lung signs. So we will report increase in weight to the healthcare provider because increased weight indicates fluid retention. We will implement fluid restriction as ordered to reduce excess intake. We will work with the patient and the registered nurse to determine how it should be implemented. For example, if a patient is on a 1,000 milliliter per day fluid restriction, You might plan for 150 milliliters with each meal, so that would be 5 ounces because 30 ml is 1 ounce. So 150 divided by 5 is going to be, 150 divided by 30 is going to be 5 ounces per meal. 450 milliliters to be given to the patient to use as he or she likes during the day, and 100 ml to be used during the night. So that's like a little over 3 ounces. That's not a lot to get through the night. Be sure to include the patient in your planning. Remember to reserve enough fluid for swallowing medications. Post a sign in the patient's room so that other caregivers know how much fluid the patient can have. You must administer diuretics as ordered. Monitor patient response. Be sure to monitor potassium in patients receiving a potassium wasting loop or thiazide diuretic. Diuretics promote diuresis. Report urinary output below 30 ml per hour to the HCP or RN because this may signify increasing renal complications. Evaluation. If interventions have been effective, the patient will return to his or her normal weight with clear lung sounds and no edema. Many patients must remain on drug and diet therapy after hospital discharge to prevent the problem from recurring. Patient education. In collaboration with a dietitian, instruct the patient, family, or other caregiver about any fluid or sodium restrictions to prevent further problems. Common foods that may have high sodium are listed in Table 6.1. If a potassium wasting diuretic is prescribed, teach the patients to eat foods that are high in potassium. Table 6.2 on page 59. They show for that food sources of potassium would be a baked potato, white beans. They're saying canned white beans, sweet potato, salmon, plain yogurt, tomato juice, orange juice, and of course the banana. The patient's serum potassium levels must be periodically monitored by an HCP or home health nurse. If it becomes too low, an oral potassium supplement is needed. Teach the patient or caregiver common signs and symptoms of fluid excess that should be reported to the HCP. Of special importance is weight gain. A patient at high risk for fluid excess should be weighed at least 3 times a week in the home or nursing home at the same time each day and on the same scale. Weight gain should be reported. Electrolyte imbalance. Natural minerals in food become electrolytes or ions in the body through digestion and metabolism. Electrolytes are usually measured in milliequivalents per liter, MEQ/L, or in milligrams per deciliter, Mg/dl. Electrolytes are one of 2 types, cations and anions. Cations carry a positive electrical charge. Anions carry a negative electrical charge. Although there are many electrolytes in the body, this chapter focuses on the most important ones. These include sodium, potassium, calcium, and magnesium. These electrolytes are maintained in different concentrations inside the cell and outside the cell because of the pumps in the cell. Figure 6.3. So nutrition notes is on page 58, and it says reducing sodium intake. Whereas dairy products such as milk are naturally high in sodium, the major sources of dietary sodium are salt and processed foods, including baked goods, canned and packaged foods, and condiments. For example, American cheese has more sodium than does cheddar cheese, and cured ham has more than does fresh pork. Patients should be taught to read labels for sodium content on all packaged foods. Drinking water may contain significant amounts of sodium, particularly if it is softened or mineral water. Because of the numerous hidden sources of sodium, patients on low sodium diets benefit from education by the dietitian. The adequate intake of sodium is 1.5 grams daily for adults through age 50, 1.3 grams for those aged 51 to 70, and 1.2 grams daily for those 71 and older. The upper tolerable intake level, the UL, for sodium is 2.3 grams daily. This is contained in slightly more than a teaspoon of salt. None of these amounts applies to those losing large amounts of sweat daily or to unacclimatized persons exercising in a hot environment. Specific definitions for reduced sodium food products have been adopted. Note that serving size is an important variable. Salt or sodium free means that there's less than 5 milligrams of sodium per serving. Very low sodium would be less than 35 milligrams per serving, per 100 grams of main dish, and then low sodium would be less than 140 milligrams per serving per 100 grams of the main dish. I'm reading on page 59 now. Electrolyte imbalances. At times, a patient may experience problems because of too much or too little of an electrolyte. In general, if a patient experiences a deficit of an electrolyte, the electrolyte is replaced either orally or intravenously. If the patient experiences an excess of an electrolyte, treatment focuses on getting rid of the excess, often via the kidneys. The underlying cause of the imbalance must also be treated. The most important aspects of nursing care are preventing and assessing electrolyte imbalances. You must be vigilant in watching for signs of imbalance in high-risk patients. Serum electrolytes are measured on a regular basis. As a general rule, patients should be checked for the electrolyte imbalance when there is a change in their mental status, either increased irritability or decreased responsiveness, or when muscle function changes. Patient education is another important nursing role. Sodium imbalances. The normal level of serum sodium is 135 to 145 milliequivalents per liter. Because sodium is the major cation in the blood, it helps maintain serum osmolality. Therefore, sodium imbalances are often associated with fluid imbalances, described earlier in this chapter. Sodium is also important for cell function, especially in the central nervous system. The two sodium imbalances are hyponatremia, which is a sodium deficit, and hypernatremia, which is sodium excess. Hyponatremia occurs when serum sodium levels is less than 35 milliequivalent per liter. Pathophysiology and etiology. Many conditions can lead to either an actual or a relative decrease in sodium. In an actual decrease, the patient has inadequate intake of sodium or excessive sodium loss from the body. As the percentage of sodium in the ECF decreases, water is pulled by osmotic pressure into the cells. In a relative decrease, the sodium is not lost from the body. Instead, it may leave the intravascular space, where the blood is, and move into the interstitial tissues, third spacing, where it becomes trapped and useless. Another cause of relative decrease occurs when the plasma volume increases, fluid excess, causing a dilutional effect. The percentage of sodium compared with other fluid is diminished. Prevention. Additional sodium is commonly administered to patients at high risk for hyponatremia, box 6.3, usually by the IV route. Individuals who have high fevers or who engage in strenuous exercise or physical labor, especially in the heat, need to replace both the sodium and water. Hyponatremia is especially dangerous for the older patient. Signs and symptoms. Unfortunately, the signs and symptoms of hyponatremia are vague and depend somewhat on whether a fluid imbalance accompanies the hyponatremia. The patient with sodium and fluid deficits has signs and symptoms of dehydration. The patient with sodium deficit and relative fluid excess has signs and symptoms associated with fluid excess. With more severe sodium deficit, the patient experiences mental status changes. These include disorientation, confusion, and personality changes. This occurs because the low sodium and decrease in osmolarity cause more water pushing pressure. This causes water to collect in and around the brain, cerebral edema, and increase intracranial pressure. Weakness, elevated body temperature, tachycardia, nausea, vomiting, and diarrhea may also occur. Complications. In severe hyponatremia, respiratory arrest or coma can lead to death. The patient who also has fluid excess can develop pulmonary edema, another life-threatening complication. Okay, there's a purple box. Actually, I'm going to read box 6.3 on page 60, which is high risk conditions for hyponatremia. The following conditions place patients at high risk for hyponatremia or low sodium. So if they've been ordered to take nothing by mouth, which would be NPO, a patient experiencing excessive diaphoresis or sweating, because you can sweat those salts out. Diuretics, you can pee the salts out. Gastrointestinal suction is when a healthcare provider sucks out the excess sodium. And syndrome of inappropriate antidiuretic hormone, which could be maybe an error made by the healthcare practitioner. Excessive ingestion of hypotonic fluids. So that could be just excessive amounts of water, which don't have any sodium. Doesn't have sodium in it. Fresh water near drowning can cause hyponatremia, and decreased aldosterone can cause hyponatremia. There's a box, purple box that says gerontological issues. Confusion. Often older patients who experience a change in their electrolyte levels will present with sudden unexplained confusion. Immediate identification and treatment may quickly relieve the confused state. The older patient's cardiovascular system is very sensitive to quick fluid shifts. It is important to remember intravenous infusions should only be provided at the rate provided by the healthcare provider. Okay, there's also a green box on page 60 entitled Evidence-Based Practice. So there's a clinical question. How does hyponatremia affect hospital length of stay? Evidence. A systematic review and meta-analysis using 49 randomized controlled trials revealed that hyponatremia occurred in approximately 20% of hospitalized patients in these studies. That's 1 in 5. Patients with hyponatremia were hospitalized 3.3 days longer than those with normal sodium levels and were more likely to be readmitted. This may be an important factor in increased hospital-related costs as well. Implications for nursing practice. Monitoring hydration status as well as fluid and electrolyte balance is an important part of caring for patients, no matter their age or health status. It is especially important to carefully monitor those at risk, such as older adults and those with comorbid conditions, since it can affect length of stay and readmission rates. Diagnostic tests. This is on page 61. The primary diagnostic test is a serum sodium level, which in hyponatremia registers below 135 milliequivalents per liter. The serum osmolarity also decreases in patients with hyponatremia. Other laboratory results may be affected if the patient experiences an accompanying fluid imbalance. Serum chloride, an anion, is often depleted when sodium decreases because these two electrolytes commonly combine as NaCl, salt in solution, or saline. Therapeutic measures. Therapeutic measures focus on resolving the underlying cause of hyponatremia and replacing the lost sodium. The HCP may order IV saline for patients who have hyponatremia without fluid excess. For patients who have fluid excess, a fluid restriction is often ordered. Diuretics that rid the body of fluid but do not cause sodium loss may be used. For patients with cerebral edema, steroids may be prescribed to reduce intracranial swelling. Inputs and output are strictly monitored. The patient is weighed daily. Implement interventions to keep the patient safe if the mental status is affected. Hypernatremia occurs when sodium level is above 145 milliequivalent per liter. So the pathophysiology and etiology, a serum sodium increase may be an actual increase or a relative increase. In an actual increase, the patient receives too much sodium or is unable to excrete sodium, as in kidney failure. In a relative increase, the amount of sodium does not change, but the amount of fluid in the intravascular space decreases. Therefore, the percentage of sodium or solute is increased in relationship to the amount of plasma. In mild hypernatremia, most excitable tissues such as muscle and neurons of the brain become stimulated. The patient becomes irritable and has tremors. In severe cases, these tissues fail to respond. Prevention. Prevention of hypernatremia is not as simple as prevention of hyponatremia. Most patients have a sodium excess as a result of an acute or chronic illness. Patients with a potential for electrolyte imbalance must have their IV fluids carefully regulated. Signs and symptoms. Thirst is usually one of the first symptoms to appear. If you eat salty foods such as potato chips, the amount of sodium in your body increases and you become thirsty. Other signs and symptoms of hypernatremia are vague and nonspecific until severe excess is present. Like the patient with a sodium deficit, the patient experiencing sodium excess has mental status changes such as agitation, confusion, and personality changes. However, This time the cause is too little fluid in the brain tissues. Seizures may also occur. At first, muscle twitches and unusual contractions may be present. Later, skeletal muscle weakness occurs that can lead to respiratory failure if it affects the diaphragm. In fluid deficit or fluid excess, no, if fluid deficit or fluid excess accompanies the hypernatremic state, the patient also has signs and symptoms associated with those imbalances. Complications. A patient with severe hypernatremia may become comatose or have respiratory arrest as skeletal muscles weaken. Diagnostic tests. The most reliable diagnostic test is the serum sodium level. This indicates an increase above the normal level. Serum osmolarity may also increase. If the patient has a fluid imbalance, other laboratory values such as BUN, hematocrit, and urine-specific gravity are also affected. See earlier discussion. Therapeutic measures. If a fluid imbalance accompanies hypernatremia, it is treated first. For example, fluid replacement without sodium in a patient with dehydration should correct the relative sodium excess. If the kidneys are not excreting adequate amounts of sodium, diuretics may help if the kidneys are functional. If the kidneys are not functioning properly, dialysis may be ordered. I&O and daily weights are strictly monitored. The cause of hypernatremia is also treated in an attempt to prevent episodes of this imbalance. For some patients, a sodium-restricted diet is prescribed. Potassium imbalances. Potassium is the most common electrolyte in ICF, which would be the intracellular fluid compartment. Only a small amount, 3.5 to 5 milliequivalents per liter, is found in the bloodstream. Small changes in this laboratory value cause major changes in the body. Potassium is especially important to cardiac muscle, skeletal muscle, and smooth muscle function. If the serum potassium level falls, the body attempts to compensate by moving potassium from the cells into the bloodstream. The two potassium imbalances are hypokalemia, which is a deficit, and hyperkalemia, which is a potassium excess. Hypokalemia is the most commonly occurring imbalance. Hypokalemia occurs when the serum potassium level falls below 3.5 milliequivalents per liter. Pathophysiology and etiology. Most cases of hypokalemia result from inadequate intake of potassium or excessive loss of potassium through the kidneys. Hypokalemia most often occurs as a result of medications. Potassium wasting diuretics, e.g. furosemide, Lasix, and hydrochlorothiazide, digitalis preparation, which would be digoxin, lanoxin, and corticosteroids, e.g. prednisone, are examples of drugs that can cause increased excretion of potassium from the body. Potassium may also be lost through the gastrointestinal tract, which is rich in potassium and other electrolytes. Severe vomiting, diarrhea, and prolonged GI suction can cause hypokalemia. Major surgery and hemorrhage can also lead to potassium deficit. Prevention. Most patients having major surgery receive potassium supplements in their IV fluids to prevent hypokalemia. For patients receiving drugs known to cause hypokalemia, potassium supplements or food high in potassium may prevent a deficit. See Table 6.2. Signs and symptoms. Many body symptoms are affected by sodium imbalance. Muscle cramping or muscle fatigue can occur with either a deficit or an excess of potassium. Vital signs change because the respiratory and cardiovascular system need potassium to function properly. Diminished skeletal muscle activity results in shallow, ineffective respirations. The pulse is typically weak, irregular, and thready because the heart muscle is depleted of potassium. A major danger is an irregular heartbeat, arrhythmia, which can lead to cardiac arrest. Orthostatic postural hypotension may also be present. The nervous system is usually affected as well. The patient experiences changes in mental status, followed by lethargy. The motility of the GI system is slowed, causing nausea, vomiting, abdominal distension, and constipation. Vomiting may further increase potassium loss. Complications. If not corrected, hypokalemia can result in death from arrhythmia or respiratory failure and arrest. The patient must be treated promptly before these complications occur. Diagnostic tests. The primary laboratory test is serum potassium level. The patient's electrocardiogram, ECG, may show cardiac arrhythmias associated with potassium deficit. In addition to a decrease in the serum potassium level, the patient may have an acid-base imbalance known as metabolic alkalosis. This commonly accompanies hypokalemia. In metabolic alkalosis, the serum pH of the blood increases more than 7.45, so that the blood is more alkaline than usual. Acid-base imbalances are discussed later in this chapter. Therapeutic measures. The goal of treatment is to replace potassium in the body and resolve the underlying cause of the imbalance. For mild to moderate hypokalemia, oral potassium supplements are given. For severe hypokalemia, IV potassium supplements are given. Because the kidneys eliminate excess potassium, potassium should be administered only after the patient has voided to be sure that the kidneys are functioning. Potassium is a potentially dangerous drug, especially when administered intravenously. In too high a concentration, it causes cardiac arrest. Only IV solutions that are pre-mixed and carefully labeled should be used. Potassium is never given by IV push. The patient's laboratory values must be monitored carefully to prevent giving too much potassium. Teach the patient about the side effects of oral potassium and precautions associated with potassium administration. Box 6.4 summarizes the precautions the patient should be aware of when taking oral potassium supplements. So I'm going to read that really quick. The tips for patients taking oral potassium supplements. Do not substitute one potassium supplement for another. This is box 6.4 on page 63. Take all forms of potassium with a full glass of water or juice. Dilute powders and liquids in water or juice exactly as directed. Do not crush extended release potassium tablets such as Slow K or K-Drew tablets. Do not take potassium supplements if you take potassium-sparing diuretics such as spironolactone, which is aldactone, or trimethoprim, also called durinium. Tell your doctor if you use salt substitutes containing potassium. Take potassium supplements with meals and report adverse effects such as nausea, vomiting, diarrhea, and abdominal cramping to the healthcare provider, and have frequent laboratory testing for potassium levels as recommended by the HCP. Prevention. For patients receiving potassium supplements, hyperkalemia can be prevented by monitoring serum electrolyte values and the patient's signs and symptoms, and by adjusting the dose accordingly. Signs and symptoms. Most cases of hyperkalemia occur in patients who are hospitalized or undergoing therapeutic measures for a chronic condition. The classic manifestations are muscle twitches and cramps, followed by profound muscular weakness, increased GI motility, diarrhea, slow, irregular heart rate, weak pulse, and decreased blood pressure. Complications. Cardiac arrhythmias and respiratory failure can occur in severe hyperkalemia, causing death. Diagnostic tests. In addition to an elevated serum potassium level, ECG changes are also associated with hyperkalemia. If the patient has metabolic acidosis, the serum pH falls below 7.35. Therapeutic measures. For mild chronic hyperkalemia, dietary limitation of potassium-rich foods may be helpful. Potassium supplements are discontinued. Potassium wasting diuretics are given to patients with healthy kidneys. For patients with kidney problems, a cation exchange resin such as sodium polystyrene sulfonate may be administered either orally or rectally. This drug releases sodium and absorbs potassium for excretion through the feces and out of the body. In cases in which cellular potassium has moved into the bloodstream, administration of glucose and insulin can facilitate the movement of potassium back into the cells. During treatment of moderate to severe hyperkalemia, the patient should be in the hospital on a cardiac monitor. Calcium imbalances. Okay, so I'm going to switch to the other PowerPoint now. Calcium imbalances. Calcium is a mineral that is primarily stored in bones and teeth. A small amount is found in ECF, which is extracellular fluid. So that's fluid outside of the cell and also not in the bloodstream. The normal value for serum calcium is 9 to 11 milligrams per deciliter, or 4.5 to 5.5 milliequivalents per liter. Minimal changes in serum calcium levels can have major negative effects in the body. Calcium is needed for the proper function of excitable tissues, especially cardiac muscle. The two calcium imbalances are hypocalcemia and hypercalcemia. Hypocalcemia occurs when serum calcium level falls below 9 milligrams per deciliter, or 4.5 milliequivalents per liter. Pathophysiology and etiology. Although calcium deficit can be acute or chronic, most patients develop hypocalcemia slowly as a result of chronic disease or poor intake. Postmenopausal women are most at risk for hypocalcemia. As a woman ages, calcium intake typically declines. The parathyroid glands recognize this decrease and stimulate the bone to release some of its stored calcium into the blood for replacement. The result is a condition known as osteoporosis. in which bones become porous and brittle and fracture easily. The woman who is postmenopausal has a decreased level of estrogens, a hormone that helps prevent bone loss in the younger woman. Immobility or decreased mobility also contributes to bone loss in many patients. That's why we have to do weight-bearing exercises. The patients at highest risk for osteoporosis are thin, petite Caucasian women. Hypocalcemia can result from inadequate absorption of calcium from the intestines, as seen in patients with Crohn's disease, a chronic inflammatory bowel disease. Insufficient intake of vitamin D prevents calcium absorption as well. Conditions that interfere with the production of parathyroid hormones, such as partial or complete surgical removal of the thyroid or parathyroid glands, can also cause hypocalcemia. Finally, in patients with hyperphosphatemia, usually those with kidney failure, often experience hypocalcemia. Calcium and phosphate have an inverse relationship. When one of these electrolytes increases, the other tends to decrease. Prevention. In the United States, the typical calcium intake is less than 550 milligrams. The recommended dietary allowance, RDA, of calcium for adults aged 19 to 50 and men aged 51 to 70 is 1,000 milligrams. The RDA for women over 50 and men over 70 is 1,200 milligrams daily. Hypocalcemia can be prevented by consuming calcium-rich foods and by taking calcium supplements. These supplements can be purchased over the counter in any pharmacy or large food store. An inexpensive source of calcium for patients who do not require vitamin D supplementation is calcium carbonate, or Tums, which provides 240 milligrams of elemental calcium in each tablet. Patients should be cautioned not to routinely take high doses of calcium without checking with their primary care provider. Vitamin D supplementation may be required in addition to calcium for patients whose sun exposure is limited. The sun's ultraviolet light causes the skin to manufacture vitamin D. Signs and symptoms. Chronic hypocalcemia is usually not diagnosed until the patient breaks a bone, usually a hip. Acute hypocalcemia can occur after surgery or in patients with acute pancreatitis. Signs include changes in heart rate, decreased blood pressure, mental status changes, hyperactive deep tendon reflexes, and increased GI motility, including diarrhea and abdominal cramping. Two classic signs that can be used to assess for hypocalcemia are Trousseau sign and Chipstick sign. To test for Trousseau sign, inflate the blood pressure cuff around the patient's upper arm for 1 to 4 minutes. In the patient with hypocalcemia, the hand and fingers become spastic and go into palmar flexion, figure 6.4. To test for Chipstick sign, tap the face just below and in front of the ear. Facial twitching on that side of the face indicates a positive test. Trousseau sign is more specific for hypocalcemia than Chipstick sign. In severe hypocalcemia, neuromuscular irritability can lead to tetany or continuous muscle contraction. The patient may have a sudden laryngospasm that will stop air from entering the lungs. Seizures, respiratory failure, and cardiac failure can occur and lead to death if not aggressively treated. Diagnostic tests. The patient with hypocalcemia has a low serum serum calcium level and an abnormal ECG. Parathyroid hormone level may be increased as it attempts to stimulate the bone to release more calcium into the blood. Therapeutic measures. In addition to treating the cause of hypocalcemia, calcium is replaced. For mild or chronic hypocalcemia, oral calcium supplements with or without vitamin D are given. Calcium supplements should be administered 1 to 2 hours after meals to increase intestinal absorption. Be sure to check compatibility when administering calcium with other medications. For patients with acute or severe hypocalcemia, IV calcium gluconate or calcium chloride is given. When a patient has had thyroid or parathyroid surgery, there is a danger that parathyroid hormone will be decreased, causing serum calcium to drop. IV calcium must be readily available for emergency use if the signs of hypocalcemia occur. For patients with hyperphosphatemia, usually those with kidney failure, aluminum hydroxide is used to bind the excess phosphate for elimination via the GI tract. As phosphate decreases, the sodium-calcium level begins to normalize. Diet therapy is an important part of treatment. Teach the patient, family, or other caregiver which foods are high in calcium. Table 6.3. Many foods are fortified with calcium. Vitamin D foods are also encouraged, especially milk and other dairy products. For patients experiencing difficulty digesting dairy products and those who choose not to use dairy products, special attention must be paid to including other dietary calcium sources in the diet. So table 6.3 lists the foods. There's the fortified ready-to-eat cereals. Parmesan cheese also has a lot of calcium. Plain non-fat yogurt. All flavors of almond milk have calcium. This is important to know for our vegan patients that maybe don't take any milk at all. Tofu, raw, regular, tofu, plain yogurt, soy milk, all flavors, that has calcium. Mustard spinach, low-fat milk, mozzarella cheese, skim milk, reduced fat milk, cheddar cheese, whole milk. Those are all dairy products. Hypercalcemia occurs when serum calcium is above 11 milligrams per deciliter or 5.5 milliequivalents per liter. Pathophysiology and etiology. Chronic hypercalcemia can result from excessive intake of calcium or vitamin D, kidney failure, hyperparathyroidism, cancers, and overuse or prolonged use of thiazide diuretics, such as hydrochlorothiazide. Acute hypercalcemia can occur as an emergency in patients with invasive or metastatic cancers, especially cancers of the blood or bone. Prevention. Although many causes of increased calcium cannot be prevented, a person receiving calcium supplements should be monitored carefully. Some patients believe that if 2 or 3 tablets a day are helpful, consuming twice as many will help even more, and the result can be serum calcium excess. Educating the public about the proper amount of calcium needed each day and the danger of too much calcium is very important. Signs and symptoms. Patients who have mild hypercalcemia or a slowly progressing calcium increase may have no obvious signs and symptoms. However, acute hypercalcemia is associated with an increased heart rate and blood pressure, skeletal muscle weakness, and decreased GI motility. complications. In some cases, the patient may experience kidney or urinary calculi, or kidney stones, resulting from excess calcium. In more severe cases of acute hypocalcemia, the patient may experience respiratory failure caused by profound muscle weakness or heart failure caused by arrhythmias. Therapeutic measures. Patients with severe hypercalcemia should be hospitalized and placed on a cardiac monitor. Unless contraindicated by other conditions, the primary treatment is to give IV fluids and promote diuresis. Saline infusions are the most useful solutions to promote renal excretion of calcium. The HCP also discontinues thiazide diuretics if the patient was receiving them and prescribes diuretics that promote calcium excretion, such as furosemide, which is Lasix. Drugs that slow calcium movement from bones to the blood may also be used, such as pamidronate disodium, which is also called Aredia, or zoledronic acid, Zometa, or calcitonin. If hypercalcemia is so severe that cardiac problems are present, hemodialysis, peritoneal dialysis, or ultrafiltration may be necessary to cleanse the blood of excess calcium. See Chapter 37 for discussion of these procedures. Magnesium imbalances. Magnesium and calcium work together for proper functioning of excitable cells, such as cardiac muscle and nerve cells. Therefore, an imbalance of magnesium is usually accompanied by an imbalance of calcium. The normal value for serum magnesium is 1.5 to 2.5 milliequivalents per liter. Magnesium imbalances are called hypomagnesemia and hypermagnesemia. Hypomagnesemia occurs when serum magnesium level falls below 1.5 milliequivalents per liter. It results from either decreased intakes or excessive loss of magnesium. Causes of inadequate intake include malnutrition and starvation diets. Patients with severe diarrhea and Crohn's disease are unable to absorb magnesium in the intestines. One of the major causes of hypomagnesemia is alcoholism. Alcohol causes both decreased intake and increased renal excretion of magnesium. Certain drugs, such as loop and osmotic diuretics, aminoglycosides, e.g. gentamicin, garamycin, and some anti-cancer agents, cisplatin or platinol, can increase renal excretion of magnesium. The signs and symptoms of hypomagnesemia are similar to those for hypocalcemia, including positive trousseau and Chvostek signs described earlier in this chapter. The goal of management is to treat the underlying cause and replace magnesium in the body. Magnesium sulfate is administered intravenously. If the serum calcium is also low, calcium replacement is prescribed. The patient is placed on a cardiac monitor because of magnesium's effect on the heart. Life-threatening arrhythmias can lead to cardiac failure and arrest. Hypermagnesemia signs and symptoms. Hypermagnesemia results when serum magnesium level increases above 2.5 milliequivalent per liter. The most common cause of hypermagnesemia is increased intake coupled with decreased renal excretion caused by kidney failure. Signs and symptoms are usually not apparent until the serum level is greater than 4, it's very high. Then the signs and symptoms include bradycardia and other arrhythmias, hypotension, lethargy or drowsiness, and skeletal muscle weakness. If not treated, the patient experiences coma, respiratory failure, or cardiac failure. When kidneys are functioning properly, loop diuretics such as furosemide, Lasix, and IV fluids can help increase magnesium excretion. For patients with kidney failure, dialysis may be the only option. Acid-base balance. The cells of the body function best when the body fluids and electrolytes are in a narrow range. Hydrogen is another ion that must stay within its normal limits. The amount of hydrogen determines whether a fluid is an acid or base. An acid is a substance that releases the hydrogen ion. The stronger the acid, the more hydrogen ions that are released. A common acid in the body is hydrochloric acid, which is found in the stomach. A base is a substance that binds hydrogen. A common base in the body is bicarbonate, HCO3. Alkali is another word for base. Sources of acids and bases. Acids and bases are formed in the body as part of normal metabolic processes. Acids are formed as end products of the glucose, fat, and protein metabolism. These are called fixed acids because they do not change once they are formed. Carbonic acid is a weak acid that can be formed when carbon dioxide resulting from other cellular metabolism combines with water. This acid can change to bicarbonate, a base, and hydrogen. Therefore, it is not a fixed acid. The ECF, which is the extracellular fluid, maintains a delicate balance between acids and bases. The strength of the acids and bases can be measured by pH. The pH of a solution can vary from 0 to 14, with 7 being neutral, 0 to 6.99 being acid, and 7.01 to 14 being base or alkaline. The normal serum pH level is 7.35 to 7.45, which is a pretty narrow range, and it is slightly alkaline. It must remain in this extremely narrow range to sustain life. An arterial pH lower than 6.9 or higher than 7.8 is usually fatal. Okay, so there's a learning tip here. It says the word acid has fewer letters and lower numbers. So it's anything less than 7.5. This is to help you remember it. It also comes first in the alphabet, acid before alkaline. So it comes first on the pH scale with the lower numbers. Alkaline has more letters and higher numbers. So anything higher than 7.45 when it comes to the blood. Control of acid-base balance. The body has several ways in which it tries to compensate for changes in the serum pH. 3 major mechanisms are used: cellular buffers, the lungs, and the kidneys. Cellular buffers are the first to attempt a return of the pH to its normal range. Examples of cellular buffers are proteins, hemoglobin, bicarbonate, and phosphates. These buffers act as a type of sponge to soak up extra hydrogen ions if there are too many, if it's too acidic, or release hydrogen ions if there are not enough, too alkaline. The lungs are the second line of defense to restore normal pH. When the blood is too acidic, the pH is decreased. The lungs blow off additional carbon dioxide through rapid, deep breathing. This reduces the amount of carbon dioxide available to make carbonic acid in the body. If the blood is too alkaline, the pH is increased. The lungs try to conserve carbon dioxide through shallow respirations. The kidneys are the slowest to respond to changes in serum pH, taking as long as 24 to 48 hours to assist with compensation. The kidneys help in a number of ways, including regulating the amount of bicarbonate base that is kept in the body. If the serum pH lowers and becomes too acidic, the kidneys reabsorb additional bicarbonate rather than excreting it so that it can help neutralize the acid. If the serum pH increases and becomes too alkaline, the kidneys excrete additional bicarbonate to get rid of the extra base. The kidneys also buffer pH by forming acids and ammonium, which is a base. Acidosis or alkalosis that is corrected by the body is referred to as compensated. The pH is returned to normal or near normal, but the gases that monitor acid-base balance, PCO2 and HCO3, are abnormal. Acid-base imbalances are caused by a number of acute and chronic illnesses or conditions. The primary treatment for each of the imbalances is to manage the underlying cause, which corrects the imbalance. The role of the nurse is to identify patients at risk and monitor laboratory test values for significant changes. Laboratory tests that are used to evaluate acid-base balance are called arterial blood gases, ABGs. As the name implies, the blood sample that is analyzed must be from an artery rather than a vein. The femoral, brachial, and radial arteries are often the most used to obtain the sample. Table 6.4 lists ABG values and what they indicate. Two broad types of acid-base imbalances are acidosis and alkalosis. Each of these imbalances can occur suddenly. This is called an acute imbalance. They can also develop over a long period, resulting in a chronic imbalance. When the serum pH levels fall below 7.35, the patient has acidosis because the blood becomes more acidic than normal. Too much acid or too little base in the body causes acidosis. Acidosis can be divided into two types, respiratory and metabolic. Respiratory acidosis is caused by problems occurring in the respiratory system. Metabolic acidosis is the result of problems within the body, the rest of the body. So that would be outside of the respiratory system. When the serum pH level increases above 7.45, the patient has alkalosis because the blood becomes more alkaline or too much or basic. Alkalosis is caused by too little acid in the body or too much base. It can also be divided into two types, respiratory alkalosis and metabolic alkalosis. Okay? Note, this is a learning tip, note the arrows in table 6.4, which you should be able to see now. In respiratory imbalances, the arrows are pointing in the opposite directions. In metabolic imbalances, the arrows are pointing in the same or equal directions. So simply remember Rome, respiratory opposite, metabolic equal. So that might help us to remember. I know we had a question on one of our tests where they asked whether something was metabolic or respiratory acidosis or alkalosis. And I think I got that one wrong. So this chart can certainly probably help me with that. Um, so it's now 9:45, and there is we've finished everything in the chapter, although I want to go back to the critical thinking on page 65. Mrs. Wright is a 77-year-old petite Caucasian woman who lives alone at home. She is on a fixed income and rarely eats calcium-rich foods. She recently fell and broke her hip. After surgery, she returned home under the care of a home health agency. Number one, what factors made the patient at high risk for a fracture? It said, the patient is, and this is on page 69, the patient is at risk for osteoporosis and thus fracture because she's an older, petite Caucasian woman. In addition, she does not get much calcium in her diet. Okay, what would you expect her serum calcium level to have been before the fall? Her serum would be low or low normal because the body will metabolize calcium in the bones in an attempt to maintain her serum calcium levels. So even though she's not getting enough with her intake, her body is going to take it from her bones. So you might not really see it, extremely low. Um, Number three, what patient teaching related to diet and calcium supplements should the home health nurse include during the home visits? Teach her about consuming foods high in calcium, the need to be compliant when taking her calcium supplements, and to take the supplements 1 to 2 hours after meals for best absorption by the body. In addition to a nurse, what other home healthcare team members might be helpful for Mrs. Wright? Well, she would benefit from physical therapy for ambulation and strengthening, occupational therapy for evaluation of her home environment and possible assistive devices, and a dietitian for dietary counseling. Caution her to avoid taking more calcium than prescribed because that can also be harmful. On page 69, number one, which of the following are functions of the sodium in the body? And so this is a select all that apply. Number one, maintenance of serum osmolarity. That is true. That is a function of sodium. Number two, formation of bones and teeth. Not the sodium, that's going to be the calcium. Control of bronchodilation. No. Control of serum glucose. Definitely not. And then number five is maintenance of cellular function. And absolutely sodium is going to play a role with that. So the answer to number one is 1 and 5. Number two, a 93-year-old patient with diarrhea and dehydration is admitted to the hospital from a long-term care facility. For which of the following symptoms of dehydration should the nurses assess? Okay, so dehydrated is what we're looking for. Number one, pale colored urine and bradycardia. No, because dehydration is going to concentrate your urine, which means it's going to be darker. It's not going to be pale colored, so that's not the answer. Number two, disorientation and poor skin turgor. Absolutely. If you're dehydrated, that can cause, especially in an older patient, disorientation and poor skin turgor. So we're going to want to check the skin on the forehead or the sternum for this patient. Number three, so number two is the answer. I'm just going to, I know it's only one answer, and that's the correct answer. Number three, which patient is most at risk for fluid excess? Okay, so fluid excess. So number one, an infant with pneumonia, probably not. I'm concerned about that infant not having enough fluids because they may have a fever, which can also reduce their fluids. They can sweat off, and there's other losses that could be occurring. Number two, a teen with multiple injuries following an automobile accident, if he's got multiple injuries, he might be bleeding out, which would be causing a fluid loss and not fluid excess. So that patient probably is not at risk for fluid excess, but rather for fluid deficit. Number 3, a middle-aged man who has just had surgery. And number 4, an older adult receiving IV therapy. Okay, so now so while the middle-aged man who has just had surgery could be at risk for fluid excess because he might have an IV, we're not going to choose that answer because there's a better answer. Somebody that's even more at risk than a middle-aged man is going to be the older adult that is receiving IV therapy. So this is something that we need to watch for anytime we have a patient that's older on an IV. Number 4, a patient gains 2 pounds in 24 hours, weighed on the same scale at 7 a.m. Approximately how much water weight is represented by the 2 pounds? Well, we remember that little tip in that box. They said a pint is a pound the world around, and a pint is 16 ounces. So 2 pounds is going to be 2 pints, or 2 times 16 is 32 ounces. So the answer is 32 ounces. I think is a big gulp. Anyway, number 5, when caring for a patient with fluid excess, which of the following interventions will best help relieve respiratory distress? Number 1, elevate the head of the bed. That is the correct answer. Number 2, encourage the patient to cough and deep breathe. That's not the answer. Increase fluids to promote urine output. That's not going to help with the respirations. And then performing percussion and postural drainage is probably not the best way to do it. The best way is just to elevate their head to semi-Fowlers or high Fowlers. Okay, so number 6, I have a patient is being discharged following hospitalization for fluid imbalance. Which instruction by the nurse should take priority? Number 1, weigh yourself at the same time 3 times a week and report changes. And that is the correct answer. We want daily weights in the hospital, but they also said, outside of our care, when the patient is at home, they need to weigh themselves at least 3 times a week. So, and report any changes. So that's the answer for number 6. Number 7 is a patient is being treated for hypokalemia. So that's low potassium. When evaluating response to potassium replacement therapy, which of the following assessment findings should the nurse observe for? So improving visual acuity, no, they never mentioned that this stuff affects vision. Worsening constipation, no. Decreasing serum glucose, definitely not. Increasing muscle strength is definitely something that we should observe for, and there's a couple of different tests that we are able to do for the patient to assess that. I think the shoulder shrug was one of them that we read about last week. Number 8, a patient is being placed on a potassium-losing diuretic. Which foods are high in potassium and should be recommended to the patient by the nurse? Bread, I don't think that's high in potassium. Number 2, potatoes. Yes, they did mention potatoes have a lot of potassium. Yogurt and bananas. So those 3 definitely should be recommended. Okay, number 9, which patient is at risk for respiratory acidosis? Number 1, the patient with uncontrolled diabetes mellitus. Number 2, the patient with chronic pulmonary disease. That is the correct answer. They are at risk for respiratory acidosis because of their chronic pulmonary disease. The patient who's very anxious is not at risk for respiratory acidosis. And the person that overuses antacids is not at risk for respiratory acidosis. They're at risk for respiratory alkalosis because antacids are going to give you the opposite of acidosis, which is alkalosis. So the answer to number 9 is 2. Number 10, which pH value represents acidosis? And for that one, you know you need a lower number. So the lowest number they show is the correct answer. And the lowest number is 7.26. And that is definitely acidosis.